Mo, hey Mo,
Hey, Ricky, here we are.
the doctor is in.
Indeed. Happy Wusa Wellness Wowie Wednesday, right? September is done. October is almost upon us. And what an amazing and beautiful day it is. How you feeling?
I'm great. How did that happen? I don't know what happened to September, but you know it's coming. On Friday, we're starting Touchtober. That's what I'm calling
October. I love this. Oh my
Touchtober.
goodness.
So, and we are ready for Touchtober. We'll talk about that in a minute. But I'm actually in New York today for an event with our friends from Cherry Blossom Intimates, and I have one of their cool
Oh,
tops.
that is so
But
jazzy. Oh
so
my
cool.
gosh, that's gorgeous.
Thank you. But New York is a crazy place. I'm just so not used to like all the noise and the traffic. And God bless you, people that live here.
I
But
love it. It just reminds you of life, and
it,
it reminds you of all the diversity and the beauty in people and the beauty in silence when you get somewhere and it's
oh my
silent.
gosh,
But
yes,
yeah,
yes,
it's a
yes,
beautiful, busy, bustling town, and it's a great reason to be up there celebrating with Cherry Blossom Intimates and
yeah. They're
just
great.
having a good time.
Yeah, great,
Wow.
great friend. So we have an amazing, lovely person on our show today, Crystal Dixon. And I'm gonna let her explain what she does because there are too many letters after her name for me to even know what they are. Okay. All I know is that she's a badass and she's a brainiac and she's doing incredible work. And she's at Wake Forest University. And we're gonna talk about racism and talk about a really cool study and racism in care today.
Wow.
And it's a pretty hot topic these days.
It is, isn't it? Hey, Crystal, how you doing? How
Hey,
you feeling?
hey, Dr. Mo and Ricky. I'm doing great. I'm fantastic because I'm here with you all. You all are just so much fun. I enjoy the show, and so I'm really excited to be here.
We're so glad you're here. We're so glad you're here. So, let's get into it. Talk to us. Tell us what you're up to and what you're
Yeah,
doing and about this research and this, let's talk about it because we don't want
yeah,
to have racism in care. We want everybody to get equitable care and have access to care and get all the right stuff. They just, Black women deserve the best of everything. So how do we get it?
that's right. And I appreciate you saying that. What's interesting about access is that people think it's enough, and it's unfortunately it's not. Once you get into the system, it's still racist against us. And which is why you all are amazing in the work you're doing. That we're being discriminated against, but who am I and what am I doing? So I'm here on behalf of the Greensboro Health Disparities Collaborative. And so the Greensboro Health Disparities Collaborative is a partnership here in Greensboro, North Carolina, made of community members, academic researchers, medical professionals. And we come together and we're really addressing racism in healthcare. And it was started by Nettie Code. Nettie Code was a local resident here. She had some differences in her treatment. She said, I need to figure out what's going on. She interviewed professors from UNC and said, hey, I think you're the right person. And they got together and created the collaborative. And so from that organization, they went into and applied for some funding through NIH to do this study to address systemic racism. So I just came in at the tail end and said, hey, I'm really interested in this. And I jumped on board.
Great.
So wait a minute, let me make sure I got this right, because people watching are all trying to figure out how to turn their test into testimony and how to turn their breast cancer experience into something transformational. So these people got together, started a nonprofit, and began to do this research in that area, in the Wake Forest service area.
Yeah. So this young lady named Nettie Code, she's not here with us anymore. She had lung cancer and she died. Mm-hmm. And they were tired of it. They were like, look, you all think it's enough to get into the system. When I get into the system, I'm not getting the treatment. I'm not getting the attention I need. We've got to do a systemic intervention to address the healthcare system. And they brought these people together, applied for a planning grant, and actually interviewed breast cancer people to say, hey, what is your experience like? They took that qualitative data and then applied for an even larger grant, which is the ACCURE project. And that's what you all probably were reading about. And the ACCURE is the Accountability for Cancer Care Through Undoing Racism and Equity. And
say that again slowly so people can Google it.
Yeah, so, and I could drop a link in the chat. So Accountability for Cancer Care Through Undoing Racism and Equity. And I can actually drop a link if you all would like.
Yeah, we'll put it in the Facebook chat. I'll put it in the Facebook
perfect. Okay. Absolutely.
Yeah.
So how does one even begin? Because I get this question a lot. We sit on a lot of panels, those of us who are in research and who are in medicine and academia. How do you even begin to identify the scope of the problem, right? When we look at racism in healthcare and in medicine and cancer care particularly, it's so pervasive. How do you like put your finger on or itemize the biggest issues that we face? What are some of the data that came out of that early study that helped us to pinpoint those things we need to focus on?
Yeah, that's a great question. So really, there was a difference in how the response to milestone in care were across race. So as you all know better than me, as it relates to the healthcare, the treatment, breast and lung cancer patients were going through their treatment and they were missing milestones in care. And they realized when they disaggregated by data who was missing the milestone in care, they realized it was a disparity. And so they started there. They said, we're going to start there and try to close that gap to figure out why is it that white patients that are breast and lung cancer patients are finishing their treatment and Black people are not. And so that's where they started with the study.
So by milestones in care, you mean like treatment benchmarks, like they're actually completing their full course of chemotherapy or completing their radiation,
That's right.
things like that?
That's right. That's right. Things that you have to do during your treatment completion program that are required to complete the treatment fully.
Wow. Wow. So when we talk to these breast cancer patients, right? We talk to the breasties. What's some of the information that came forth about why they think some of those barriers exist? And then the flip side of that question is, what did some of the providers think? And is there a difference between what patients think and what the doctors think?
Yeah, so a lot of patients were concerned about, I know we did multiple publications on this, around this issue. One of them was just perceived pain, for example. A lot of you all know, a lot of Black patients were not being responsive to their pain needs versus white patients. And so also they just weren't getting any kind of support during the process. So for example, we have breast cancer support groups. White patients were getting referred to support groups more than Black patients were. White patients were given more resources than Black patients were. And so there was a difference in support even throughout the process, which is where the patient navigators came in to actually provide those services that were missing during their patient treatment experience. So those were the type of qualitative data, and I can certainly share with Ricky the link to all those publications to show exactly what questions were asked and what was shared in that conversation.
That's fascinating. One of the key, I won't call it a complaint, but one of the comments that we get a lot are that the support groups, they don't look like us. They may show up once and they find that there's a room full of people who have totally different issues and, maybe different perceptions about their care, different races that don't necessarily reflect some of the welcoming environment that our breasties might need. And so I wonder if that's been some of what's been said also by the people participating in these studies.
Oh yeah, there's one story that stands out to me, Dr. Mo, is a patient we did some interviews after the fact, and a patient was talking about something as small like a packet of lemon heads. So when you walk in, when you do treatment and radiation, you get lemon heads to kind of curtail that taste in your mouth. And there was an incident where the person sitting at the desk, every time a Black woman would walk by and get the lemon head, she'd pull the bowl away and say, no, in other words, you can't have any. So little microaggressive experiences,
Wow.
just petty microaggressive experience. That wasn't what was like the reason for the study, but it was just those kind of experiences that patients like, little things like that, no one's looking out for me, no one's following up with me, and but the interesting thing, Dr. Mo, is that we realize this is not just from providers. Like the actual healthcare system is inherently racist and designed to only further the treatment of whites over Blacks.
Yeah.
And so this is what this intervention kind of called out and was like, look, we can give you all some implicit bias training, cultural competency is just simply not enough. In fact, there's no data that show there's actually improved outcomes from those. So, you know what I mean? So we have to do something more. And that's when we called the system out and said, the system is what's the problem. It's not the providers are perpetuating the system, but the system itself is inherently broken, as we say, and that's what we mean by that.
Yeah.
So how do you separate the system from the people? Because what is it? I mean, like, I hear you that if the system could be made up of a bunch of racist people, are the people just racist? Is that pervasive? And how did you get racist people to admit they were being racist?
I think it's particularly the training with the Racial Equity Institute, what they do, which is what a lot of the nurse navigators went through before they went to the study, was we focus on systems thinking. We don't really focus on bigotry, because we realize that if you're following, so to answer your question fairly about the difference, if you're racist and you follow a system that's inherently equitable, I think there still can improve some outcomes. Because who you are doesn't really matter. It's how you're being trained that's creating these inequities. And I think unless you bring them together and you have implicit bias, of course, it's going to affect it. But I think it's multi-layered as well. But I think the systemic approach is more effective than the actual individual approach. That's just me talking.
I get that. And that resonates with me in the sense that when we do a lot of DEI training, whether it's for corporations, for hospitals, whether it's for students, right? For student doctors who are all trying to learn how to really show in their treatment that Black Lives Matter and that diversity and equity and inclusion are not just buzzwords. We talk a lot about the word structural racism, because the structure itself, the actual house of cards of the healthcare system, it's baked into the cake.
That's
and
right.
So the people are just the pawns. They're moving through the board, but the board
That's
has
right.
already been set up a certain way.
That's
And so, the question becomes, one, when people recognize that the board is stacked a certain way, how did they operate from within this framework and fix it? But more importantly, how did you guys pick out the systemic issues that you wanted to tackle for this study? How did you figure out which ones?
Sure. So when they got the planning grant, they did some interviews with breast cancer and lung cancer patients. And from those interviews, they had the data that said, hey, we have a problem with how we're receiving care. The quality is different. I'm not getting follow-ups. There's a difference between me and my white counterpart. They're noticing that there's differences, statistically just significant differences across race in those focus groups. And they took that experiences of missing milestone and treatments of care. They also, the nurse navigator, for example, wasn't probably trained at all. So they went in. So the study had 4 things that attacked out of this study. Also, there wasn't anything inherently in the system to actually notify anyone that there was a mistreatment in care. So what the ACCURE project did was it trained the nurse navigators to actually be trained in racial equity lens. They built a real-time registry system, which is a patient electronic medical records that actually notified the patients and other navigator of the missed milestone of care. They also provided provider level data and practice level data to summarize it into clinical performance reports. So you know more about that, Dr. Mo. And also they had HEAT sessions, which stood for health equity education and training sessions. And that was specifically for the providers to possibly address implicit bias as well. But it also brought the data from the planning grant to the providers and said, hey, this is what we found. This is what we're going to focus on. And then they rolled into the big study after that, the ACCURE project, which then focused on the very things that they found, which was pretty much difference in response to treatment and completion rates between Black and white breast lung cancer patients. And the great thing about this study is it not only closed the gap in patient treatment completion rates between Black and white, it raised the care for everyone. So it wasn't just Black patients that got an increase. Everyone was benefiting from the intervention. So it shows that equity is good for everyone.
Yeah.
People get kind of blinded and say, wow, what about me? All lives matter. Well, yeah, in this study, this intervention raised the impact for all involved in the study. So it just shows that it's helpful for that. So to answer your original question, Dr. Mo, the feedback from the focus groups from the breast and lung cancer patients was how they started the focus study on.
Wow, this is so comprehensive, right?
Yeah,
right.
And so we're talking about not only training the navigators, because we know that when patients have navigation, when somebody is helping usher them through their treatment journey, whether it's through their survivorship, whether it's through chemo, surgery, radiation, whatever, the utilization of resources is better. We know that they are referred more often for and will better utilize things like plastic surgery consultation, they get reconstruction. They're more likely to be adherent to their treatment plans when you have almost an accountability buddy in a nurse who's saying, okay, where are we with this? What do you need to get you to the finish line? So training those nurse navigators is huge. But when you start talking about performance report cards, right? And how are we doing in real time? That's important data that hospitals don't always get. Doctors are just moving along through their day, bing, 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 room after room, myself included. But when somebody says, well, let's sit back and look at how we're doing. How did we do over the last month, the last 6 months? How many patients actually got where they needed to go
That's
in
right.
the right amount of time.
Right.
That is a really powerful data.
And you know, they took the race, so they wanted to study race stratified care quality metrics of their own patient panels and compare it to the practice, like to the average practices of that. So they wanted to see where they fell versus what was on average. And it kind of kept them accountable for that.
Right. And it's not to be punitive. It's not for punishment,
Right.
but it's to
No,
say,
for learning.
let's look at
That's right.
whether or not this is really working. Are we really utilizing these things? And if we're not, what are the barriers in us utilizing? And I think this is something we should extrapolate, Ricky, to talk about clinical
Yeah.
trials, right? We can look in real time and we can see how we're doing with clinical trial discussions, not necessarily enrollment. There's a lot that goes into enrolling somebody.
Right. But just
are
the
we at
process of
least-
education. Yeah.
Are we at least educating and offering patients, options for clinical trials, whatever ones we have available or the ones that we don't know about, and we have to figure out a way to sort of account for that because institutions that may not have those trials are not going to offer those trials. But there's got to be a way to look in some sort of real world data way at how we're doing and having that conversation and report that back to clinicians. And this is a great segue into something else for looking at our clinical trials and when we try, because that piece of it, making sure that we're actually doing that and how we're doing with it and figuring out what are the barriers even in our processes is what's going to change practice among the providers, because patients are starting to ask. They're getting smart. They've been watching the doctors in and they've been listening to Ricky and they've been reading up on
Yeah.
let me tell
They're
you
mad
something.
as hell, right? They're gonna ask the questions, right?
They have come into my clinic saying, well, what trials am I eligible for? And I'm like, wait a minute, what? And it's a beautiful thing to see.
Yeah.
But we got to step up our game and make sure that we're meeting those needs and that we're meeting those benchmarks. So Crystal, this is a huge work.
Yeah. How do we scale it? How do we scale it? Like, we need it in South Carolina and Georgia. Georgia has the worst numbers. I just came back, and we need it in Ward 8 in DC. We need it everywhere. How do we use
what?
template?
Ricky and Dr. Mo, that is our dream. That is our mission here, is to make every healthcare system believe in this and adopt it. And one of the hardest things for us is when we built that real-time registry system was sustaining it, because there's high turnover rates. You have to have physician champions in the process.
Right.
People leave. It's so many things, and it creates that accountability for true health outcomes. And I'm realizing that, as you all know, healthcare is a profitable business. It's about business, and someone's life has to be at stake to make that money. And I believe, unfortunately, that a lot of people of color are the lambs that are being used to make that bottom line. And then you have pharmaceutical companies coming in and incentivizing it. And it's all this, it just gets terrible. But the goal is to make every healthcare system adopt this. And it was so hard to get this published because of the obvious foundation of just the fact that we're calling out racism in the healthcare system. And it's very stigmatized to say that people didn't swear to the Hippocratic Oath and are doing their best job. It's not about the individuals all the time. It's what are we training our medical students? What do we, there are a lot of institutions that are getting on board to start training, but then you get into these racist systems. It's like, well, how are we going to get the system? Because this is the thing, we push the system like this. And as soon as you get your foot off, it goes right back.
Yep. Because
it's inherently designed to only advantage whites. Always, every system. This is just healthcare. Every system. And I'll say this: the Racial Equity Institute mentions this. Every system has something that's inequitable, when they call it something different. For example, education is the achievement gap. You got judiciary is disproportionate minority contact. All right. You got health disparities. I can go on. You got the wealth gap. We can go on. Every system is inherently designed to advantage whites over blacks, and the healthcare system is no different.
Right. I was on this panel, and I talk about this story a lot with Mamo at Mamo's event at SABC a couple of years ago, and it's not even racism, it's privilege. So I was on a panel with this lovely white doctor whose name I have like blocked from my mind. But she's in front of like 100 Black women talking about how, well, my office gives out gift cards. We give out food cards. We have Whole Food gift cards. We have Uber cards. We have whatever. We have resources for Black women. We have all the stuff. We can give you whatever. We can pay for you to get here and make your chemo appointment. I'm like, well, how do people know? How do they know about it? It's like, well, I don't know. Somebody in my office must be handling it. I don't know. I said, well, and all they have to do is ask. And I said, sweetheart, they're not going to ask. So I'm a
Right.
poor Black woman. I don't have any way to get to chemo. Can you please
Right.
give me a gift card? Not going to happen. But in her mind, with her best intention, she felt like she was doing the right thing because she had the stuff available. But
Yeah.
there was a huge gap, even with her staff, actually getting it to the patients because her patients had no clue about the stuff that she had.
Mhm.
I said, well, how many gift cards do you have in your cabinet? Because I don't think you're giving any out, girlfriend.
Right.
But I mean, how do you stop that? She did not have a clue. She actually got mad and got walked off the panel, which is pretty interesting because she was pissed off at us. But she thought she was doing the right thing.
Yeah, that's what we call fixing fish in the Racial Equity Institute. Fixing fish, that's, Racial Equity Institute tells a story about if you go to a lake and there's fish that one fish floats at belly up dead, what are you going to do? You're going to look at the fish. But if all the fish start coming up belly up dead, what do you do? You look at the water. And she's not looking at the water. Perhaps why is it that they're not asking? Why are they needing? It's not her responsibility to fix the wealth gap or the issue of the transportation, but a lot of people are creating temporary fixes and they're not addressing the root cause of the issue, which is the system, which is why this intervention was like, look, we're tired of giving out gift cards. We're trying to fix the system, and so you're right. I mean, that's unfortunately the way people have been trained. And it's just, unfortunately, it's helpful. Everyone needs it, but it's not going to fix it long-term.
Yeah. Yeah. But I think, I always, say, how does the patient feel, kind of being a patient, like, we don't know what's going on. We just and we're sick. We don't feel good. We're scared. We don't know even, how to even know sometimes that we're not getting the best care because that's all we know. That's our normal.
Mm-hmm.
Right. So, and so we're kind of the victims, not only of the disease that we're dealing with, which is horrible enough, but also of the system we're walking into. So we walk into the hospital thinking somebody's going to help us. And, we take what we get because that's all we know.
Yeah.
I think that's where programs like this, and I think that's where advocacy groups really have such a huge opportunity and a power to really focus on health literacy, right? Before you get that diagnosis, you already kind of have some ideas about where to go for good information and about how things are supposed to look and feel in that interaction. And you understand some things. And it's not the case for everybody. It's not the case for most. But I think that the opportunity for us to help standardize what patients expect, almost like I know that every hospital has a patient bill of rights, and they probably post it somewhere in their hospital. And it's like, the patient has the right to whatever. But imagine if you were armed with the things that you should know when you go to your doctor's appointment, right? Whether it's for a well visit or whether it's a new cancer diagnosis, there's some things that you should expect. And I think that we can really drive that point home for patients, especially, so that they would then be able to be a little bit less caught in the crossfire and have a better understanding of at least the minimum of what it is that we deserve from our health system. And we as advocates and as community groups, we can do some of that work while we're simultaneously working on the system and working on the inequities there. Crystal, let me ask you this question. How important do you think is representation? Everybody keeps saying, representation matters. Is it just creating a more diverse workforce that's going to fix this challenge, or is it more to the story?
Oh man, that's a great question. I think it's more to the story. I think, unfortunately, a lot of physicians and healthcare providers that look like us often are victims of the very system that we're trying to fight. They're often trained to navigate that system. There's an assimilation going on in that system. There's some survival techniques going in that system. And as a result of surviving the system, you're kind of, you're exchanging that for lives, for lack of a better word. You're looking out for alliances more so than lives. And I think a lot of tokenism is going on. You're hiring people to look the part, but you're not giving them any power.
Ooh-wee. So what does that translate into? How do we fix some of that stuff? In a perfect world.
Sure. So the Racial Equity Institute defines racism, they say racism is social and institutional power plus race prejudice. That is what racism is. And if we want to fix
Say that again.
Sure. So racism is social and institutional power plus race prejudice. And so it's also racism is a system of advantage based on race, and racism is also a system of oppression based on race. And so I say all that to say that in order to fix this whole, how do we fix this? We have to give people of color who are actually, and I say people of color because we look like the ones affected by this,
Right.
power in these positions of authority. You've got to give them the opportunity, the authority to make decisions that are life-saving, policy, systemic, things that are actually going to save lives. Don't put me up there and then say, you can have a seat, I'm going to do this, or can I do this? No, you can't, but still sit there and represent our institution. We're seeing a lot of that. We're seeing a lot of people who are qualified for positions, and because they're doing too much of a radical change, they're sitting them down or they're not hiring them. So I think we have got to get people in positions that are in those power-making positions empathetic to the needs of our communities. Other than that, it's just very performative.
I love that you said that, because, you know, they bring us in as captain of the Titanic, right?
Yes.
You know what it is. You see it. There's a new CEO and the company's going down in flames, and everybody can see it. And they're all like, don't do it, sis. Don't do it, brother. Don't do it.
That's
and,
right.
You know, and all of a sudden, here we are. We get this golden opportunity
That's right.
to try to fix everything that, you know, that's been messed up for generations.
That's
And I think you're right in that, you know, we have to be given these opportunities, but also given the resources and the support to be successful in
right.
these positions, right?
That's
And
right.
that comes from the top, not just from, you know, from the trainee level. We're training cadres of, you know, empathetic medical students and empathetic scholars at this medical school. I'm on faculty, and that's great. But you know what happens when they get into their clinical rotations?
Mm-hmm.
Right. They face the old boys network, and it gets beat out of them because they want to pass their rotations, because
That's
they
right.
want to fit in, because they want to become surgeons. All
That's
of a sudden, every good and valid question that they had, they're zipping it up.
That's right.
And they're locking it away. Yeah.
That's right.
Yeah.
That's right. That's right. You know, and whiteness, to say this, it's a very unique experience. I fundamentally believe that there's a stark difference between people of color's outlook and cultural values and whiteness.
Mhm.
Not all white people are bad white people, but I feel like the culture of whiteness can have an incident and move on like business as usual. Whereas we feel, you know, you almost have to train others to feel.
Yeah.
Some whites need to be trained to feel, and others feel, because there are a lot of white allies out there. But I think the system in itself is not designed to feel. It's designed to do business.
Yeah.
You know?
And when you're sick, you don't really think of a hospital as a business, except for when you sign up to go to the hospital, the first thing they say is, okay, how are you going to pay? You know,
Right.
they remind you you're going to pay money. But if you think about it, we have such a shortage of Black doctors and Black nurses. What about Black hospital administrators? How many Black CEOs are there of hospitals in the world? I have no idea.
I have no idea.
Yeah, they're small numbers. We could query the Academy of FAHCE. We could query the academy and see how many there are. But health equity is a big buzzword right now in the Academy of Health Scholars and those folks who are in health leadership and management. And there's not enough, and there are very few sorts of pipeline programs that will help those clinicians who even want to go into hospital leadership and administration. And I think that too is an area where we can have some influence, because there should be. Right. Well, there should be faculty interns who are learning how to be health administrators and, you know, hospital leaders and chief medical officers and all these things. You know, those doors need to swing open for us as well. So interns at every level, believe it or not, because, you know, the numbers just still aren't there.
Yeah.
Yeah, we need more of that. We need more of that. Ooh, a lot of work to do. So how can we clone you, Crystal, or get more people in, you know, other cities and other systems?
You know, I am just serving one of several in the Greensboro Health Disparities Collaborative. We are a family. We do this together. Our goal is to hopefully clone the study and to create that across every hospital in the country. That is our mission. It's a very lofty goal, but we are starting slow, and we have been to several medical institutions that have presented. They're interested. But our goal is to really save lives and not to put patches on people, not to give them a gift card, not to suggest they're not helpful. We're trying to change a system that is creating health inequities that are killing people every day. This COVID-19, people
my
are not only that because of the COVID-19, the type of treatment you're getting. I do a lot of work. Environmental racism is my background. If you're living in a polluted area and you go into the system, you're likely going to die on top of having less quality of care.
Mhm.
Yeah. I mean, you have to beg for good care. It's
Well, I'm sorry. I really view this whole COVID thing, this vaccine thing, as an ism. To me, people who are not getting the vaccine are an ism. I don't know what to call it, but they are putting their values, their beliefs, right or wrong, whatever you want to call them. I don't want to judge. Well, I do want to judge, but I'll try not to. Against the greater good. Against the greater good. They are working against the greater good in a situation where people are dying. And if think about it, what would this world look like if everyone got the vaccine? We wouldn't have COVID. We'd all be going on airplanes, hanging out, going on vacation, seeing our family, not worried about our kids and our grandkids. A woman called me yesterday. Her 4-year-old daughter has COVID. She has a 1-year-old baby. She's in the house trying to keep her babies apart so the 1-year-old doesn't get COVID.
Wow.
She got it from school, from a teacher. How crazy is that? So that's what we're dealing with, because people are an ism. They're saying, I don't really care about anybody except for myself, and this is what I believe, and I don't care.
And you know what, Ricky, I appreciate you sharing that, because on top of that, with the over influx of people and not enough labor in the hospitals to address the issue, of course, there's going to be some hierarchy and some implicit bias happening, and who's going to get preferential treatment, who's going to get it. It's inherent where we're going to be pushed to the bottom.
Right.
If there's 2 beds, there's 2 white people and a black person, you're likely going to, and I'm just arbitrarily saying
ventilator, one white person, one black person, who's going to get the ventilator.
That's right. That's
you got to call it out for what it is. But you know what, though, the cancer doctor in me is an optimist, is an eternal optimist. And I see so much opportunity in COVID because everything is just laid bare, right? The brokenness of it, right? The lack of resources, the fact that the emperor has absolutely no clothes. And that, like, this is, it's unbelievable to the point of like, are you kidding me? This is where we are in our healthcare system. Like, it's on the verge of collapse, not once, but twice now as a result of this. And it has really shined a light on disparities in such a way that the government is taking notice, in such a way that pharma is taking notice, in such a way that patients and everybody is like, hey, we're all sounding the alarm here. And so I feel like we got to do something with the bells in this chorus. And I think there's some opportunities for us to really try to seize on this and continue to expose it and pare it down. And like, there's no other explanation. When you've gone through your process of elimination, right? And when you get right down to it, these are the issues that COVID is exposing, because we know that our screening mammograms came to a halt last year, and who was most affected? Those in rural communities, those in Black and brown communities, less likely to get screened, less likely to get treatment, less likely to get trial. I mean, the data is astounding.
It is.
And now's the time for us to begin to do something with it. And so I love that your study is giving us the something to do with it in ways that are so really tangible, in terms of the results. Can you tell us a little bit more about like what made the care better? What made the change? If you had to sort of pinpoint what those things were.
How did you get a racist person to even do the training?
Racist.
So
no, it's a good question. So, you have to have physician champions. You have to have people inside the system to say, I'm a person of power and I give my stamp of approval. We're going to do the study, number one. A lot of people try to do this and you don't have the internal support, it's going to crumble. You have to have that support. So what came of the study is that I think Dr. Ramesh made your question, but essentially missed milestone in care. Black people, as you all know, are not diagnosed as much as white people for breast cancer, but they're dying more, right?
Yep.
Dying more because they're being ignored in the system.
Yep. So
this study actually pulled the covers and said, what are y'all doing where they're not getting breast cancer as much, but they're dying more? What is going on? And just to backpedal really quickly to say something about that, the Congress published in the Institute of Medicine Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. This was already commissioned by Congress. This has been revealed. This is actually why the Health Disparities Collaborative launched the study, because they showed when they control for every factor, income, rate, income, age, access, that we often blame health disparities on. When we control for that, they found it was race. So this has been a long known fact. So when they lifted the sheets and they said, hey, y'all are not giving Black patients the same attention in response to the missed milestone in care that you're doing your whites, we've got to do something about that. Also, your physicians are not aware of the role that they're playing in their referrals, their treatments, their implicit bias, all of that. And so they pretty much honed in on those missed milestones in care, which is why they built a registry. They actually had to go in and build something that was never there and say, okay, let's say Dr. Mo was going in for treatment, flag, she missed a day, flag goes up, nurse navigator calls. Whereas before, they'll miss a treatment, everybody go on with the day. Well, non-compliant, next. So whereas if it was a white person, they missed a treatment, oh my God, doctors, where is Susan?
Right.
Susan has got to be here. And Susan lives. So they called that out and required everyone in the study to get that response when they missed something. So that was the crutch of the actual, and it was 4 parts to the study, but that was really what it focused on in terms of helping people complete treatment, because they weren't, these were early stage 1 and 2 breast and lung cancer patients.
So you mean to tell me, because what I heard you say, I'm gonna paraphrase, and I'm gonna use my Philly on you. You mean to tell me that just giving a damn made a difference?
That's it, Dr. Mo.
Really? Really?
That's
That's the crux of just give a damn.
it. Pretty
Wow.
much.
And there you have it, folks.
That's it.
Wow.
Because when they see us, like our sister Ava DuVernay says, when they see us, they don't see us. We're invisibilized. Our voices, you can't hear our pain. What we need, oh, you'll be fine. Literally the data shows that they think we have a higher pain tolerance.
Yep.
So they don't even follow up with us.
Yep. 2017, medical students, surgical residents, students said that they think Black people have thicker skin and fewer pain receptors. 2017, 2019, 2020, people still have these perceptions.
Right.
Much work to do.
I just found an old study too. This is from years ago, but Black women are much more likely to delay following up with a doctor after an abnormal mammogram. So 20% wait more than 60 days to follow up compared to 12% of white women. So where was that doctor that read the mammogram and said, you're in trouble, you need help, right?
Mm-hmm.
And then another stat, only 69% of Black women start treatment within 30 days of their diagnosis, compared to 83% of white women. So what's happening again? Where's the doctor? Where's the system saying, hey, sweetie, you need to get into chemo right now. You need to schedule your surgery, right?
I find it to be multifactorial just based on my own practice. Because many times there is a spiritual component. They want to talk to their pastor. They want to pray. They want to kind of go back and consult with family. And then they may want to think about it and not just jump on the first thing that some doctor says that they need. And so I find that my Black patients do need a little bit more time to digest. But what's needed, because I'll call and I'll call again, but somebody has to say, what are the barriers? What's the thing that's keeping you from making this decision? How can I help you make this decision? A lot of times it's fear, it's money, it's faith, right? All 3 combined, because they're worried about the bills, they're worried about the chemo, they're worried about losing their job, they're the breadwinner, all these things that you don't get to in the office visit when you say, I'm sorry, Ms. Jenkins, you have cancer, you need chemo, and then the doctor walks out of the room.
Right.
Who's going to help that person deal with all the stuff to get them from here to there? And that's where, go ahead, Crystal, you're right, that's where.
No, I was going to say, if I knew Dr. Mo, that will make a difference, because just knowing her through this whole webinar, I would want to go back. I feel connected to her. And a lot of our patients, to her point, don't
feel connected to the doctor.
Don't. And it can look like us. It's not all race. There are doctors but us.
Oh yeah, right.
You know how it is. So it's just, how can you invest? And I understand it's not a lot of time, but how can you truly invest? Because everyone doesn't need to be a doctor.
Yeah.
I had a
relationship.
I had a relationship that I text Mo about this morning. I talked to this woman, and she's metastatic. She didn't even know what kind of breast cancer she had. She just finished chemo, had surgery, and she now has a staph infection, and the surgeon wants to take her implant out. And she called me to say, well, should I let him do it? And I said, immediately I'm texting Mo, I'm always texting Mo, like, are you in surgery? I need you, she has a staph infection, but she doesn't trust the surgeon. And so she wants to get a second opinion, and rightly so, but I said, well, tell me more about your care. So, I can't even go here, Ricky. I've had issues every step of the way. I don't trust any of these doctors. I wish I lived in a different area. I don't trust anybody. And so I'm scared now because this doctor wants to cut me again.
Mm.
And, but I mean, she didn't know a lot about her, what she should expect, but she knew that she was hurting and she wasn't being treated the way she thought she should.
She didn't feel seen, to your point, Crystal, and helping somebody feel seen doesn't take hours, right? It's sitting down eye to eye and face to face and saying, you know what, I see what's going on with you, or you know what, I don't feel like I'm connecting with you. Where are you? How can I reach you?
Mhm.
Right? And that is not dependent upon race. And so when I talk to students, I love bringing patients. Ricky knows, because I'll drag her along, come talk to my class. I'm giving a lecture on whatever, because it is the relationship that changes behavior. Relationship changes racism, right? Relationship changes how a doctor is going to look at a patient and what they're going to think in that moment, and how much time they're going to spend, and what they're going to offer, and how far they're going to go, how many nurses they got to call, all the things. And so the more that we can put these faces and put these relationships into place, the more sensitive and compassionate I think our healthcare providers will be to even work within the constraints of the systems that exist. Because that's what it is. They're all checked out. They're like, well, I got to go, see you later. And somebody else has to deal with, the nurse has to deal with, the social worker has to deal with. And there's so many issues that everybody just drops the ball over and over again. It's someone else's problem, and you get that Swiss cheese effect, and that patient is lost.
Yep.
Lost.
Yeah.
Totally lost.
Yeah.
Yeah. Ooh, we have a lot of work to do. So what should we do, Crystal? Like, you have a solution.
And how can we support you in this study? What can we do to
Sanjay,
amplify?
what do you need? What do you
You know
need?
what? You guys have just having this conversation and sharing your viewership with the work we're doing is an amazing start. Honestly, it would be amazing to tell all of your cancer friends who are in positions of power, look at this study, consider it. We are offering consultations to help people get this started. We're working on that right now. Our members are flying across the country giving presentations. We've gotten emails talking about how can I do this. If you can help us spread the word about the Cure Project, that is all we're asking for. That is how we're going to save these lives and change these systems. We've got to increase that accountability because there is none right now.
Well, let's write an article. We can write an article, get it on blackdoctor.org, and
that'd be awesome.
Papers, and let's write something. If you help me, Emily can help us work on that, and we can write and at least get into the Black press and start the conversation.
Sure, and I'll share that with our collaborative as well. We co-author a lot, and I think they'd be thrilled to join that effort if you all would have us do that. That'll be amazing. I really, really appreciate that.
And talk about your results more. Talk about
we're going to drop that link for you there, but essentially it was a major increase before the intervention and after, and it was statistically significant. And the numbers we don't talk about because I didn't get approval to talk about them, but it is published. So y'all can share that.
Well, there are any patients who would like to share.
That's exactly where it's going. You know that.
I know it. Any patients who participated who would like to share, if they are at liberty to do so, because I think as we talk about clinical trials and demystifying what that looks like and participation in those, even in the focus groups, that sort of thing, I think that sharing as much of those experiences will help encourage other people to participate, because the trials take so many different forms. There's registry, there's surveys, there's all sorts of quality of life and qualitative type data that doesn't necessarily involve a science experiment on you. Right. Gives us important information about how we're going to move forward, especially for Black women and breast cancer. So we want to encourage people to see what it is so they can, feel at ease about participating in trials as well.
And Dr. Mo and Ricky, I will say this about the Cure Project. That's important to know, particularly related to the results, that there was a 100% success in closing the gap in completion of care for Black and white patients, and improve the completion of care for both Black and white patients.
Isn't that phenomenal? Well,
But the
those,
gap is
those are the
gone.
stories are going to tell the story.
That's
So
right.
incredible.
let's bring some patients on the show. Let's,
Yeah, that was our
about them.
goal.
Yeah.
I will extend that invitation to the collaborative and
Yeah.
they will be thrilled. They
Yeah,
will be
do another show with patients and they can tell their story and how they felt good and secure and
Beautiful.
safe and heard, to your point, both of your points. Yeah.
Mhm.
Wow.
Wow.
Oh, wow. So how can
Thank
people
you.
reach you? Thank you so much for that.
Sure. I can, my email is dixonct@wfu.edu. I'm at Wake Forest University in the Department of Health and Exercise Science. I can drop, you want me to drop this in chat for you?
Just don't say it again. I'm going to put it in
At
back.
Dixon, Dixon, C as in cat, T as in Tom, at wfu.edu. And I will gladly connect them to the collaborative. We are a family, like I mentioned, and please, we encourage you to look at the publications on our website to see all the work that's been done. We've done other work outside of the actual CURE study. We have many members that are scholars that do work that offshoot the study. But our goal, this right here is what we're trying to do. And you all have been a blessing to the collaborative today. You really have. You have no idea.
No, it's been our privilege. It really has, and we're doing hopefully what we set out to do every single Wednesday night. We started this at the beginning of COVID, and Black Doctor has found favor, shown us enough favor to keep doing this every
Thank you
Wednesday
so much.
night.
Yeah.
So we hope it's been relatable and reliable and real information, because that's what we're here to provide. So
Y'all are
Doctor's in.
Yeah. Next week, we have a great pink table talk story. And we're going to send out an e-blast of how you can spend Touchtober with us. So look for all kinds of good things in Touchtober.
Right.
We have a really, really big secret. We're going to save that secret.
Save it. But we're just going to say breast cancer awareness is great, but it's Breast Cancer Action Month.
Action.
Get
for Action
ready.
Month. Get
Get
ready.
ready.
Take an action. So thank you.
Thank
Breast
y'all.
Thank you.
Love you. Thank
Take
you.
care.
so much.
See you guys next week.
Sweet.
Breasty love.
Breasty love. Breasty love.
Bye-bye.
Bye.
Bye-bye.